Taken. So for the last presentation for this case, we have two speakers, Catherine Admay, who is in the Department of Political Science and Public Policy and the Duke Center for International Development. Catherine is a lawyer. She founded the NYU Law School's first international law clinic and founded and directed the Duke Law School's first international development law clinic. She served as legal counsel, legal consultant to the Greensboro Truth and Reconciliation Commission, and as a legal scholar contributing to the South African Truth and Reconciliation Commission. She's also worked for the Legal Resources Center in Pretoria and Gazankulu, South Africa, the NAACP Legal Defense Fund, and Office of the Legal Advisor of the United States Department of State, and with private law firms in Washington and Seattle, and she clerked with the Honorable Betty Binns Fletcher of the United States Court of Appeal of the Ninth Circuit in Seattle, Washington. And Catherine teaches in the areas of human rights, law and development, global health, and comparative constitutional law and socioeconomic rights. The other speaker that we have is Tom Nicholson. Tom is an associate in research at the Duke Center for International Development, who focuses on developing new mutual aid mechanisms to increase access to high-quality medicines and global health services. He is also a founder and chief executive officer of Advanced Access and Delivery, which is a nonprofit that supports health and delivery partnerships in India, South Africa, and Peru. Prior to doing his current work, Tom was a project director for 5 years, running a primary healthcare population health grant from the Doris Duke Charitable Foundation's Africa Health Initiative, which came to Partners in Health and Brigham and Women's Hospital and Harvard Medical School. And he worked with the National University of Rwanda and the Rwandan Ministry of Health. And he's also worked on multi-drug resistant TB in the prison and civilian sectors in the Russian Federation with Partners in Health, and has been involved in global TB policy since 2005. So Tom and Catherine.
Thank you. So we'll make this really quick. It really builds off the wonderful presentations by both Christian and Salman that lay out the factual predicate, as it were, for what we're going to argue that Admay will lay out at the end of this presentation. So to start out, let's just situate this in the history there, since we've been all over the 20th century. We're now in 2015. A lot of the science that Christian mentions and that Salman mentioned has been integrated, but in a very particular way. And some of the preconceived notions of scarcity and the false choices between TB infection treatment or prevention and DOTS have not entirely disappeared. So we'll see how that manifests in the current guidelines. So as someone was saying, we know TB is hard, and despite all the cost effectiveness studies, it also is complex and requires a serious investment from health systems and from partners. It's intertwined with poverty and marginalization, both economic and political. We know this. The battles to date, if Paul and others in the room yesterday would agree that just the fight for MDR-TB treatment access was a significant battle that lasted, I would say, over a decade. And Meche and Salman and others in the room were involved with that. And TB, we should expect no different from preventive treatment for TB as well. A lot of the same frames are being used by international institutions to justify why TB infection is not something that should be treated, that were used for drug-resistant tuberculosis back in the late 90s. In some ways, however, it's almost more naked and obvious, and in some ways more pernicious now, because I'll show you how in the current guidelines. Just to reiterate that you can't bring TB into an elimination phase on a population level without implementing a comprehensive approach, as Salman laid out. And this has, of course, been done in places like Alaska. We were fortunate enough to have the Cuban HIV and TB programs come up to Duke University a few months ago, and they laid out, they do a very similar program, a lot of minor differences, but a comprehensive approach. They actively look for cases. They test the cases, even though they only have one lab that deals with it. They put people on the appropriate therapy, and then when it comes to prevention, they both take institutional measures, which are more expensive, but they also treat TB infection and exposure. So moving on to the document at hand, the 2015 guidelines on the management of latent TB. So it starts out really well. Actually, it incorporates a lot of the information that we've been talking about. It includes those new regimens that Salman listed, rifamycin-based regimens, including one called with rifapentine, which is why I'll call this preventive therapy instead of IPT as I discuss preventive therapy. So It outlines the new medicines, how they're well tolerated, shorter approach, less interactions with the health system, therefore less expensive. And these were issues that they've repeatedly claimed are reasons not to do preventive treatment, as Christian outlined. But at the end of the executive summary, it takes quite a U-turn, and an unusually direct one. So this is actually worth reading. I'll start in the middle. But the guidelines were intended to provide the basis and rationale for the development of national guidelines after they had said, this is guidance on evidence-based practices for testing, treating, and managing LTBI in infected individuals with the highest likelihood of progression to active disease. So this is evidence-based, targeted for the people with the most likelihood of progressing to active disease. And then the second half says, guidelines are primarily targeted, which is not true, but they're primarily targeted at high-income or upper-middle-income countries with an estimated TB incidence of less than 100 per 100,000 in their population. Resource-limited and other middle-income countries, which is an interestingly broad way of saying it, that did not belong to the above category should implement the existing WHO guidelines. So not these guidelines they're talking about with new regimens even, but the existing WHO guidelines. So the old treatment for those high-risk groups that are allowed being HIV positive and child contacts below 5 years of age. So this set a lot of our hair on fire, and it was a really a very important moment for us to realize just how blatant this kind of delineation is between rich and poor health systems. So in general, just very basically, this excludes both poor countries and sick countries, very strangely. So if your rate is 105 per 100,000, but you have all the money in the world, they're still recommending in this document not to treat latent TB. So there's internal contradictions in terms of how important resources really are. They kind of pair these two criteria together and mix them into this quadrant, which I'll show you, which is very bewildering. It ignores the variability of resources differentiation within these countries, many of which are federal systems, rich states, poor states. If you're going to pretend to be scientific about using resources as a measure for whether or not to do something, surely you should recognize that there are huge differences from Karachi and Lima to rural areas to anything in between. And so it's an extremely blunt way of classifying countries based on gross national income. And it makes ineligible 34 of the 40 high-burden TB or MDR-TB countries for TB prevention treatment, which is pretty stunning for me. So if we look at how they did this exclusion, this is the numbers that we came up with based on Hooton and Dodd's analysis in 2016 of the worldwide estimates for TB infection. So Salman mentioned that even the WHO guessed that it was about a third of the world. This analysis we're basing it on is more conservative, and it says only 1.6 billion people have TB infection. So according to these guidelines, the red area is not eligible for TB prevention treatment. Now, the reasons they give for this are, on one level, the TB epidemiology. There's a passing reference to it in the document itself, and that has curiously translated to the very round 100 per 100,000 number, which is very pleasing to the eye, but one suspects is not actually based on a rigorous reading of the data and the meta-analysis. It seems very curious. And then the other criterion is, of course, the gross national income, which is a cousin of GDP, and which the World Bank then tumbles into their assessment on whether it's an upper middle or a lower middle income country. So the vast majority, so these are the countries that actually have quite a bit of resources, like say Peru, which is an upper middle income country, a place close to our hearts, that also has an incidence rate of over 100 per 100,000. So they are not eligible. And I can tell you, just in the last 2 weeks, I've spoken with the head of the Peruvian TB department, and they cite this guideline as the reason they're not treating it. So this is not an academic exercise. And then this group, you're talking about, it's certainly over 1 billion, but this is where the vast majority of TB cases are. And we'll look a little bit more into what countries are included in that number. So as I mentioned, doesn't include HIV positive and children, which amounts to only, actually surprisingly, about 24 million. So about 2% change, just a very slight difference in terms of eligibility. But again, a direct reading of the guidelines suggests that they should be using for HIV positive and under 5s isoniazid preventive therapy and not the newer regimen. So still don't apply the new science to a poor setting, which is, for me, very striking to hear. So we looked at who are the countries that are flirting on the borders between these categories? Which ones are likely to pass over it in the near future? Who's passed over it in the last 10 years, if you're looking at this as any kind of rigorous guideline? And it's overwhelmingly China, former Soviet Union countries, which have significant capacity. In the case of former Soviet Union countries, they actually have, within their legal and health system framework, some, pardon the phrase, latent capacity for treating disease in its infection stage. So a lot of that is just reactivating pieces that are already there. The country here that's about to cross it would be Peru, right? So what should a Peruvian national TB director be thinking at this moment? Is my epidemiology going to be so different that we change our whole toolbox at some point? And it's really, these are notoriously unreliable numbers, incidence numbers reported in a passive way going to the World Health Organization. Very few people would put any serious stock in it. I actually tried to use it during my fellowship at Duke as a rigorous data source, TB incidence as reported by the WHO, and they sent it back saying it's not rigorous enough actually to cite. So this is the number that determines it. Is there really a discernible difference between this Peruvian program now and maybe in 5 years? And in 5 years, they could also be demoted by the World Bank based on an economic recession back to lower middle income. So anything could happen, and it has very little bearing on the actual epidemiology at the site, the resources that are existing on the national level. So this is a list of all of the alleged collaborating authors. This to me is very striking. I know a lot of these people, and I know they didn't write this. They may have been involved, they've been called, sent some materials, they wrote back saying, I'm not going to oppose this. I doubt they even said, I'm not opposed to this. I know several of these names are involved actually in the kind of work that we're doing. So to me, this is very telling that this huge list of names is cited as the kind of the process by which this happened. At the top it says, under the overall direction of the director of the TB program, and the Ministry of Health of Italy strangely funded it. So this is different in some ways than another report I'm going to show you after this. It's kind of processed or laundered, if you want to be unkind, through all these other experts, comes through the system, and then this guideline just appears with very little actual evidence base in the annex. Here's a different, so how do we get here? Here's a different look at a kind of WHO report. So this one we know is actually written by the leadership of WHO. This came out just in May, and we had to screenshot it for reasons I'll tell you, but it was titled Tuberculosis Tamed, What Gets Measured Gets Done, as a review of the last 10 years of TB control in the world. So this is after knowing that TB incidence has tripled in Indonesia and Philippines, and there's 1.8 million deaths they're registering now instead of 1.5 year over year. There's over 10 million people with active disease. And so we saw this, several people on this email chain saw that this report was out with this title. It was confirmed that it was written by the leadership, and we said, this cannot be. And if you read the documents inside of it, it's very glowing about the achievements of DOTS, how many people might have died had DOTS not been there, these very kind of interesting arguments. But within a few hours, we were getting really fired up and thinking about using advocacy channels to say, hey, people are being honest. Like, this is an idea of control that resonates with some people at international institutions. The idea of taming an epidemic, and taming being control, not elimination being a concept of control. So very quickly it was changed. So we made sure that we grabbed this while it was still publicly available. It was changed to toward ending TB within a few hours. But it was also an interesting reflection for me as other members of the activist community, instead of making hay out of this, decided to try to fix it. And I'll leave that where it is. Just to explore this idea of different ideas of what control means. Is control elimination? Is it eradication? Is it stasis? I wanted to compare these guidelines from the WHO to just a kind of a thought experiment. This isn't part of our paper, but there's a county in Alabama, a town specifically, that has rates of TB higher than Kenya or India. They've got hundreds of cases of latent TB and dozens of cases of active TB in a town of only 3,000. It made quite a bit of news, but as you'll see, it's extremely challenging. Despite this is one of the poorest states in the country, bottom 3 in terms of its own national income, if you want to count the states as national income. It's just down the road from where the Tuskegee experiment was centered. There's a deep distrust of the public health community in this area. And there's a lot of people with TB infection who don't feel sick, who they're asking to come in and get treated and go on therapy. So this is challenging. This is hard. This is in the poorest, one of the poorest states in the United States, and definitely the poorest county in the state. So there's no hospital there. There's no community resources. This will be hard. This will be expensive. But can we possibly imagine that the CDC would not do what we put up here? Working with the state TB controller, keeping the guidelines as they are. Under no conceivable scenario would the CDC change their epidemic control guidelines based on which county in Alabama this was happening. The same approach applies in Perry County as it does in Fulton County or wherever they're based, Cobb County. So I think it's important to think, just try to figure out how we got to this point where a technical assistance body that's overseeing in a sort of federal arrangement recommends one set, has a consistent epidemiological control framework for the people that it's responsible to. And I would suggest it actually shares a lot of similarities with WHO. There's a huge racial and economic divide between the kind of people that come from Atlanta to Perry County and talk to them about what this is not some sort of idea of national unity that's leading this situation. There's actual antagonism between the people in Perry County towards health officials. It's majority black. Towards health officials that are coming in telling them what's good for them. So this has a lot of similarities to the questions of colonialism and domination and hierarchy that we've been exploring. But why is it that it's unthinkable to think the CDC would change the guidelines for a poor state or a poor county based on their national income or the fact that they have a rate of TB in the 300s per 100,000? So to explore a little bit just how questions of accountability and responsibility link in with this scenario, which to me is very shocking, Catherine's going to walk us through a little bit.
I'm going to be emboldened by my friend Salman to sort of do some things on the board as well. So one of the reasons that we have used the accountability frame is that you will hear often that public international law will really get you nowhere, especially if you have litigation in mind, right? So the argument for using the language of accountability is to distinguish it really from litigation. So we're going to talk a little bit more about that tomorrow, Lynette. I'm really interested in the idea of actually bringing court cases using national law when you're trying to use public international law and you're dealing with an international organization. And Bia and Mario, you've been dealing with this question, right? How do you try to use the instrumentalities that are available to you? So we've resorted to this framework because we haven't gone here yet, litigation. So when I teach law in a public policy school, I'm actually in public policy, not political science, just for those who are watching. And so I always say there's like a kind of a heuristic, right? There's facts, standards, jurisdiction, what I call implementation and enforcement, chess moves, which is a legal term, and then the bottom line. One of the reasons I love teaching in public policy is that you'd never have this kind of conversation in a law school about whether the bottom line is being addressed by the whole instrumentality of the law. So I'm really interested in my public policy students getting to think a lot about bottom lines in relationship to these other categories of legal analysis. So what we've heard the last 3 presentations really have been what lawyers call the factual predicate. How can something this astonishing really be allowed to go on? One of the things that my friend Tom said was, look at how clear it is here that there's something tremendously wrong in the world. And I was just talking this morning with Sinead about legibility. I mean, it wasn't really legible to me. It took me a long time to figure out there's something really wrong with this paragraph. And it's not very legible to a lot of people. And I think one of the tasks of this kind of gathering is for us to make it extremely clear what's wrong with this. We have to have a very strong bottom line about what's the policy problem here, how did we get here, right? And what are we going to do about it? What kinds of tools do we have, whether it's political accountability, moral accountability, social accountability, legal accountability. One of the other benefits of transformational accountability discourse is that you're not leaving it clearly in the hands of lawyers. You're basically saying, we have to tell you that there's a legal problem here, and we're hoping there'll be some kind of political zing that goes along with that. So people start to say, this is unacceptable. You're not going to get normal people to call this unacceptable because they just don't follow it, right? So we need to like figure out how to make it more legible. Let me go back to where I'm going. So long as we're using this idea of accountability, I'm going to explain further this heuristic. We need to understand sort of a working definition of accountability. And the one that I use, and a number of theorists in this area, so, Cohen and Nye and others that, political scientists would invoke, would be that when people exercise power, law is always about power, right? When people exercise power, they have an obligation to explain their reasons for their rules, right? For what they've done, for their practices, for their rules. So this is pretty profound. To tell power, you have to give us reasons for the exercise of your power. And furthermore, your reasons have to be sound reasons, right? You can't just have like, it's my prerogative, right? It has to be that there has to be some account that's based in some kind of empirical argument for why you can have that illegible decision that we're going to have 1 billion people not be eligible for preventive therapy. What is the reason for this? So, of course, as a lawyer, I'm always looking for the counter arguments. Where is it in this document that they say what they're doing, right? And they give us 5 words, basically resource availability, which we've been hearing about all morning, and this current TB epidemiology. And we've heard that both of those arguments are very problematic arguments, right? So what I want to talk about now is, in addition to the kind of logical arguments or scientific arguments that you can make for how absurd this is, to tell people you don't have the resources to do something people actually do have the resources to do. And if you try to use the resources that you have in Karachi, Pakistan, in order to do this preventive therapy, we're going to cut you off. The unbelievable nature of that kind of engagement with resource availability is not even at the level of cost effectiveness anymore. It's a strange Orwellian kind of resource availability argument. So I would like us to think a little bit about what standards from international treaties and from the bodies of law that have been generated to interpret those international treaties, what standards could we go to if we want to have a legal argument about what's happening at the factual level? Because we don't want to confine it to a legal argument, but that's one of the tools in our toolbox is to have kind of the legal discussion about it. So the first thing that you would do when you're dealing with the World Health Organization, and you're a lawyer, is to look at the Constitution of the World Health Organization and say, what is it that your Constitution binds you to do, right? This is not some kind of policy document. This is your legal founding document, and all kinds of principles of law suggest that you have to act within the power you're given. So if you act outside of that power, it's ultra vires. Outside of your power, you're going to be bound by constitutional principles to follow the provisions in your Constitution. I mean, it's like unbelievable. These are beautiful standards that we've got to work with, right? In terms, the facts are bad, but the standards are good. So when Bia said yesterday, we don't need a revolution in standards, part of the argument is, I'm going to show that to you today. So Article 1, this is like binding law. It's not preambular. It's the thing you're supposed to do. Says that the World Health Organization's objective shall, big language in the law, it's not would like to, shall be the attainment by all peoples of the highest possible level of health. This all is really a problem when you've got 1 billion people on the wrong side of the eligibility line, right? So what are you doing, right? And then we've got the same thing going on the bottom of these preambular parts. Lawyers will fight with you about whether the preamble has the same kind of binding effect, but it's supposed to be explanatory, interpretive. And, we get here in the preamble this understanding, and, lawyers are a lot less stupid than people give us credit for, right? We get it that there's power involved, right? And there's iniquitous power, there's huge inequalities in power. And because of that, we make this chess move analysis, which is to say, we need to build in this understanding that there's going to be discrimination. People with power are going to hurt people without it. And so how do we set it up so that that doesn't happen? We proscribe discrimination. We think about all the ways in which people are going to try to get out of this rule, and we say that's not possible either. And so, of course, without distinction for economic or social condition, you'd be saying, why are these poor countries, why are all these countries that are the, what do we call it this morning, Rob? The sick and the poor are really being hung out to dry at the same time that we have this as our mission. So the second part of the World Health Organization Constitution I really want us to attend to here is the notion of science. Right? It's really important to everybody in policy that you do things on the basis of science. You have empirical work, factual predicates that help you do what you're supposed to do to advance the common well-being. And the World Health Organization's second article says that they shall be advancing work that will eradicate things like TB, right? Whether it's, latent TB infection or otherwise, and that they're going to take all necessary action to attain all the objectives, right? So there's a lot of provisions here that say to us, why are we not doing this when this is Article 1 and Article 2? Again, the preamble says we need to extend to all people the benefits of this knowledge. One of the arguments that Tom and I are going to make, the World Health Organization could do a lot for us if it would just get out of the way, right? It doesn't even have to do anything good. It just needs to not draw these lines, right? And then whatever the benefits are that have already been, discovered, let those benefits, Comstock and whatever, what was it, 1950? Right, how can we be in 2017 when you have somebody who's come up with the knowledge we need so long ago? So this is the legal principle, right? It's not just a logical principle that we shouldn't stop science and the benefits of science. The second source of law that in an article that the four of us wrote, great drama last year, in this article we looked at the what's called the International Covenant for Social, Economic, and Cultural Rights. So the nature of the human rights framework is you have these two separate covenants. I teach all my students using Roger Norman and Sarah Zaidi's book. And there's a kind of a fateful decision, as you call it, to separate these two covenants. But look at what this covenant says. The covenant says that we are supposed to, I'm going to start with actually the health part, right? So that when it comes to health, what does the covenant say? It says that we're looking again, very much in the same line as the Constitution, of everyone to the highest attainable standard of health, and that we're serious about this. We're going to have the full realization of this right. And again, we're really interested in prevention, treatment, and control of endemic diseases. Like our case, exactly. So what's the problem here? There's two problems that we need to talk about. The first problem is that it says the state parties to the present convention. So you're going to get people saying, well, Admay, it's nice that you have got Article 12 looking a whole lot like the World Health Organization Constitution, but why is Article 12 of the covenant, why does that have anything to do with the international organization? And that is really one of the challenges for lawyers. We have to figure out how we can imply into Article 12, even though it doesn't say that the World Health Organization is bound, that they too are bound, that this organization is also bound. This is legally difficult, right? So this is where you have to sort of build a bridge, and you have to think about how do you build the bridge. But one of the people, there's a whole set of people who are building this bridge, and that's the kind of thing where you can look at our situation, you can say it's broken, right? We have this beautiful set of standards, but we can't enforce them, right? Part of the reason is we don't have a J to take it to, a jurisdiction, a place where you can go and have that body analyze the facts as failing the standards. That's what a J body does. It says these facts are in violation of these standards, and therefore you have to do something differently. You don't have that. How can we try to make a situation where it's possible for an organization to face its own constitution and face these covenants and say, we really ought not to do that. It's going to get us into trouble. Somebody's going to make hay about it. In a way, part of what you're doing when you do this kind of political accountability is you're setting up the concern that there'll be a conference at Harvard. And then there'll be some proceedings that are I don't really like to say that entirely, that, it takes Harvard, but it takes us making those words more legible, making them understandable in terms of how incorrect they are in relationship to the law. So what are we going to do to make Article 12 and Article 2, which is where it was before, how are we going to make it binding on international organizations? That's a legal challenge, right? So in this article that we just wrote a year ago, the argument that I made was we have a real change in how we're thinking about international law. International law doesn't operate on its own anymore. It's embedded in something we call global governance, right? And so international law was about states, and global governance is absolutely not. Global governance is about states and non-state actors and international organizations, and we have to understand that there are going to be ideas that come from the straightforward international law, like state parties are going to do this, that are going to have a kind of bearing on, even if it's not straightforwardly through the direct language of the text, but implicitly through the fact that we're all part of a system on these international organizations. And they are predictably going to run, right? They're going to run. They're going to say, you can't do that to me, Admay, because it doesn't say anything about the World Health Organization there, right? So how can I bind these people's feet? That's sort of my interest. Like, what are we going to do? So the work that's been done at Maastricht guidelines, the Lemberg principles, a lot of like lawyers and professors have gotten together and said, let's talk about this stuff. Let's think about how we could make these connections. And interestingly enough, one of the bodies of the UN Charter, the International Law Commission, made up of law professors, some amazing like human rights law professors, like one of my heroes, John Dugard from South Africa, who like used public international law to do human rights revolutionary work in South Africa. This white old guy was kind of considered, he wasn't old then, but he was considered one of the the dragons of the land, because he could talk in these very neutral terms of public international law. What he was really doing was human rights law, right? So he was on the International Law Commission, and he and other people have convened a drafting group to come up with the draft articles of responsibility for international organizations. Now notice, right, instead of accountability, we've got responsibility. So what's going on with this, right? It's all this language. It's all driving towards the same point. We're trying to figure out, we can't necessarily say we're going to sue you. We can't sue you based on Article 2. We can't actually even sue the World Health Organization for failing to live up to its standards, because just as Roger said, it's a feature of the Constitution that the only way that any kind of claim of constitutional insufficiency can be brought is before the World Health Assembly or before the ICJ. And so you'd need a state to say that what the World Health Organization is doing fails its constitution. And if you're not going to have that, and it's actually quite a difficult process under Article 73, what other ways are you going to do it? Okay, so one of the problems in this area of standards is how to actually read this language. And in this article we wrote last year, we talked about how we have to see that the law supports what we call a gold standard of medical care. Whatever the gold standard of medical care is, the best medical care you can come up with to actually cure people, right? It's the highest attainable medical care, right? The attainment by the peoples of the highest possible level of health. That language, a little bit watered down maybe, when we're talking about the highest attainable standard of physical, mental health, right? It's very clear that it's the highest and it's for everyone and there's no discrimination. It's like both of those documents say those things. So we're getting a lot of juice from the law to be able to go there. The other thing that we can see is that this provision says that we actually want to have these standards realized, right? It's not that we are just going to leave it as a standard. We want them actually enforced. We want this to happen. It's a matter of, it's going to have to happen that we're going to accomplish these grand goals, right, through international assistance and cooperation, especially economic and technical. And this is part of how we get the international organization in on the hook, right? It's this language. Interestingly enough, many people have said, when you're looking at the international covenants, you kind of have a non-starter legally, because there's this progressive realization clause that tells you that countries can go slow, they can take as long as they want, it doesn't matter. But if you actually read the progressive realization clause and you look at the jurisprudence around it, there's nothing of that. Lawyers are not up for that. Some of them at least, right? So So what you can see here is through international assistance and cooperation, that's where we're going to get the IO, right? Especially economic and technical. We understand that we're in a partnership with states and international organizations to bring about the principles behind Article 1 of the Constitution and the health requirement of Article 12. So the interesting thing to me as well is that, I'm going to go back to this realization clause one more time, is this question about the fog of cost effectiveness. It's really important as a legal matter what law can do for us here. Seems like this has been a huge part of the history of TB and what we can do about it. So I'm really excited that lawyers can have a bearing. One of the questions is, does Article 2 tell us that there has to be all hands on board? Every organization that can provide international assistance of a technical and economic sort needs to be part of a mutual framework of solidarity? Or does it tell us, in other words, it doesn't matter what the cost effectiveness situation is, whatever we need, we come up with the money to pay for it. That's what we do. It's going to be expensive, but we don't let Marion, Alabama hang out to dry. Like, it's a legal responsibility. You don't get to say, we're not going to accomplish Article 12 or Article 1 of our Constitution. We have to do it. The other reading, unfortunately, of this provision is that actually this provision says that we have more than 200 different kinds of rights to health. So we all understand that in national constitutions, countries can formulate their right to health however they want to. Many of them actually use this language, but what's a totally novel idea is that an international right, that Faisal is, it's set out, it's cast forth as everybody, everywhere, a universal right, decontextualized for the reason that you don't want the context and its lack of resources to make it so that you can't accomplish that right? So it's a good reason for universalizing in that situation, right? What happens if you have a reading made by, very prominent health scholars? What happens if they read it differently, right? So the reading of two prominent health scholars is that we should understand Article 2 to be saying that it's all states on their own. They get to do what they can do. And the person that, I'm going to put this on is this guy, David Fiddler. He's not alone. Ben Meyer, who's one of my colleagues at UNC. Fiddler says, people argue that the right to health cannot be universal. A person's right to health is relative to his or her country's level of economic development. And his argument for that is directly hinged to this point here, right? That he's getting out of there. And what's crazy for me is he's basically read out the bolded language. So I spent a lot of time being really nervous about this legal argument because I was wondering, how is it that I'm reading this provision and these words are meaning something to me and they just read out of the interpretation? So one of the things we have to understand about any kind of lawyerly analysis of health is you can have lawyers who are, really not looking for ways to implement rights. They're looking for ways to really constrain them and take them in a direction that makes it so that despite everything, despite the effort to have non-discrimination be central to the whole design, you lose, right? So one of the other things I want to point out with a little bit of time I have left is that even if we can't argue that the World Health Organization is directly legally liable for the failure to perform these standards, the failure to conform with these standards under the covenant, which is how lawyers work. Always looking for, if we can do this, great, and if we can't do this, then we're going to do something else, right? Even if we can't directly argue that these sources of the law are binding, we should be able to make a kind of estoppel argument that we were hearing from Mona yesterday, which is to say, when an organization sets itself out as the organization that is the lead agency for health, and when it has everything it says about itself kind of flowing from a first position of enshrined in what we do, right? Here it is, this fact sheet that they've got, like the World Health Organization's Constitution enshrines the highest attainable standard of health as a development right of every human being. This is a key fact, starts out there, right? When an organization does something like that, in a way, it gives the rest of us a right. We're entitled to rely on their presentation of themselves, right? This is not in a format that's impossible for people to read. This is in a format that's very easy for people to read, to be able to see that the organization is actually setting out for us to be able to rely on what it's saying. So when we heard from Mona yesterday, right, that those who wish to invoke international law must themselves abide by it, this is the kind of place we would go, not only to the Constitution, but to the fact that they advertise it as prominently on their website. Interestingly enough, they do invoke this. They say to all their subcontractors, we need to make sure that we take a human rights-based approach to health and all these kinds of elements, right? Unjust power relations. This is what the World Health Organization is saying are there human rights obligations around health. Are they saying this doesn't apply to them? Right? Is that what's happening? What I'm wanting to argue is that we can do what Shakespeare talks about, hoisting somebody on their own petard, right? If you're going to say that this is a standard for everybody else, you need to be understanding that someone's going to come after your petard to say that it's time for you to do the same thing. Now you can see here that also in this sheet, basic idea about non-discrimination, how does it work out that you have 1 billion people on the wrong side? And then the point about rights and duties and the problem about who has these duties, because that's what the issue is around Article 12 saying the states have this obligation. Here, the World Health Organization, which is probably going to run from any kind of accountability under Article 12 of the covenant, here it says accountability is for states and other duty bearers, and that they are answerable for the observance of human rights. And if you talk about what human rights is, it's going to be the right to health, right? One of the things that's going to be there for them. So we've got some standards to hang them on, let's say. The last thing that I want to say, and that I find the most distressing and perplexing, and it's one of those experiences that I get from Roger, he talked about. On the one hand, this is dismaying. On the other hand, this gives you hope, right? So the last thing I want to say is that buried in these guidelines, right under the sort of summary of how these guidelines render more than 1 billion people ineligible for care, they say remarks. We need to have strict human rights adherence and the highest ethical consideration. This is an Orwellian situation for me. I can't stand it when I see stuff like this. It makes me really crazy, and it makes me and every other lawyer kind of, it's like the red flag for us, right? Like, you cannot say stuff like this, and it is not the case that as a matter of law, you could murder somebody in Fifth Avenue in broad daylight and not have somebody say to you that counts as murder, right? So we have to say at Harvard and other places that this kind of thing is not acceptable, and we cannot let our fellows make it not so easy for us to do that. Let me see if there's one last thing to say. I guess the last thing I'd like to say is to go back to what our friend Doris said about how we need to figure out how we can find a spot, occupy it, right, and grow it. And that is the case with these standards. When we have standards like this, the things that we don't have to have a revolution about, we use these standards as our wedge. We use them. We say you have these obligations. It's clear you have these obligations. And then we have to essentially make the road by walking. We have to be the ones that come up with some version of enforceability. It may not be before the International Court of Justice. I'm pretty much with Roger about the value of that, right? But it's going to be in some other kind of terrain, and it may well be in the terrain of political accountability. That's it.
Thank you, Catherine.